next speaker is Dr. Andrew McBride. He, in addition to having an MD degree, has a master's degree in public health. What? Oh, okay. And he is the health commissioner of Stamford, Connecticut, and acts as the advisor to the schools on health issues. And as we found out earlier, he is a new member of the board of directors of the foundation. He will be addressing us on his health department's response to the Lyme disease issues.
Thank you, Ed. Good afternoon. Doesn't reach? Okay, well, I'll have to come over there and, what happened to it? We'll do this. I'll stand up here and do this. Will the hand mic, does it have enough batteries on it? We'll see, and it's, I guess we are, you can just about hear me without a microphone, is that right? Okay.
Can the tape pick them up without the microphone?
No. Just clip it on your phone.
Oh.
Maybe record it.
Can you hear me? Okay. I'm the health director for the city of Stamford, and several years ago, about 3 years ago, we had an opportunity to work in the area of Lyme disease. I had made the first contact with Karen and Tom about 3 years ago when we were asked to do a follow-up for an infected tick that was found in Stamford, Connecticut. With that, we started our own program up with Lyme disease. And I think I'm quite proud of what we've done in Stamford, and hopefully you can find out a little bit what we've done and maybe replicate that in other areas. Well, the machine's not working? What's going on here? Now is it working? So far, it's been a technical disaster. This whole talk has been technical. Now, I just worked the thing.
The fan stuff.
Well, thank you. Do we have the other one?
You have a backup slide projector.
You can take another 2-minute break.
What happened to it? Just died? The motors? It's been making a lot of noise. It's just sort of like it took my presentation to really break its back.
May even be able to return to the.
You know, it used to be a time when there was television. You have these things that would go over and say, we're having a technical problem, and they don't have that many of those that much. Except at the NBA Finals, they had one of those. Now, I'm sure these slides will be upside down. Okay, here we go. Whoa, it's better. It's a better machine.
We had it small before because of the light.
Oh, okay. Now, is this the plug to this thing?
No, this is mine. I'm trying to put it away. Put the other one in. Yeah.
Yeah, it's working. Okay. Stamford, Connecticut is located in Fairfield County. It's about 35 miles or so from New York City. It's a commuter town for the most part in the past, but now it's less of commuters and it's more of a corporate headquarters. It has in it what might be considered a traditional kind of city, some row houses and the like, and on the other hand it has more or less what you consider suburban house that you'd expect out of Stanford. This house happens to be from our housing inspection file, which is, this house has lead hazard, which is another problem here, but that house looks terrific, but it has lead, and I'm sure I've been around the island here. They have a lead problem here as well, so, but that was, in fact, that was, a youngster was poisoned in that house because they were rehabbing the house and they did the outside, and the lead dust from the outside, the siding that's new there, was got inside and affected the child. So we had to condemn that house. That's a condemned house, by the way. It's all right now. It's better. It's okay. It's a very diverse community. Ethnically, it's about 16% black and 10% Hispanic, and mixtures, people from all kinds of ethnic groups are there. A lot of Eastern Europeans and South Americans are coming into Stanford. It has a beach, not as much beach line as here, but it has a community beach there with beachfront. It has, sunbathers and the like, and it has two ridges that run north and south. Oh, excuse me, that's a little problem there. It's just that camera, the camera just catches anything. It has two mountainous ridges that run north and south, and about 65% of Stanford is actually, could be considered deer territory. And if you look at that area, that is tick territory for us, and in the lower right-hand corner there is Phyllis, who's right here, and we brought her live. She's right here, right before you, before your eyes, there. So we do have a very significant area for deer and tick control. What we did was involve the department, which is has 100 or so people in the department. Those are the department heads, and around the department heads we have aides, and there's a senior. We have a senior citizens health promotion program that we've got started there. We have nursing, we have housing inspection, and laboratory. And those are the laboratory. Those are the directors of the health there. We have a laboratory which does traditional public health laboratory work, which is water testing and lead testing, blood drawing. We have one of the few health departments that have a bone marrow registry, which we've done a bone marrow registry, which you might have heard about, and all kinds of good things. And we have a very aggressive and committed group of people. One of the areas that we stress, and this is probably the most important aspect of Lyme prevention and control, is education. And we use the local media. That's the local media, that's a local channel that we're getting coverage there, in which we had our papers. That's in the foyer of the government center, and we presented our papers there so the public can come by and see what we have, what we've accomplished in various aspects of it. And some of it's been lead, some of it's asthma in schools, and the other was Lyme disease. And we promoted Lyme disease very strongly in our community, and we're seen as a source of information for not only in Stanford but other communities as well. Sometimes it's you get publicity just by being there. So the art of being there. I think Woody Allen said that 2/3 of success is being there or something of the sort. And it's because we're there, we're in New York, and we've been able to get regional coverage and national coverage in Stanford. We made Stanford, about, I guess, 1 or 2 years ago, Newsweek ran a thing on Lyme disease, and the mouse, there was a Stanford mouse there. It was Stanford's mouse. We went out there, and we tried to, they took pictures of me and Phyllis, but the mouse made the Newsweek. And we've been in New York Times, and on, what was it, Good Day America? Was it? Nightline. That was Nightline. They made. And you'll notice that an important aspect of this thing is to have a health director with a strong enough ego that allows his staff to go out there and get the publicity and not himself. Although I happen to be out of town when he came with it. But it really is important. I'm hoping I'm not playing it too light in terms of the importance of dealing with the media, knowing and having appreciation of the media, and use the media for to promote positive health messages as well as the negative health messages. Our approach, when we first got involved with it, was to really get involved with what might be considered the activist groups. And our first activist group was, of course, the Lyme Foundation. There's Karen there. Those are it's a natural group to work with this foundation. The Arthritis Foundation is another area, and another big partner for us happens to be the Connecticut Agricultural Extension Station, which does a lot of basic research in Lyme disease. So we made contacts with these various activists and people dedicated to the field, and we've gotten very good results. So those of you who are new in this area, hook up with people who are the normal activists, and you'll get a lot of returns, I feel. We also made this part of our regular health education outreach. This is we have a senior citizens health fair every year, and this was part of the senior citizens health fair, and part of that, which you can't see too well, is the Lyme disease brochures and the tick specimens and all that, and people really respond to it in our area. We make this, we put up our bulletin boards outside the health department for the public to see. And we also deal with other, which might be called the natural constituents. The health department has relations and deals with other agencies and companies and the like. This is the water company. We happen to be, this is the Stanford Water Company. And there you see Phyllis giving a lecture to the water company staff there. And it's an area where the water company has a great deal of land around the area. There's a lot of land work and management that's done there. And the workers come in contact with wildlife and ticks, and we give lectures to them. Usually you find a very good response. They're looking at the ticks there, and we've passed ticks around. When you have live specimens and all that, and those of you who've been involved in the education know that, there can be a tough group to work with, some of those outdoor workers, but they listen with Lyme disease. The fire department's been another area, another group that we've worked with, as well as numbers of landscape people, the corporations that have land, their staffs, schools. We've lectured this to student bodies. So where we have, but our most, I think our most important direct service has been the tick collection. I wouldn't say that's the most important, but one of the most important aspects of our tick collection services, because there we can do a lot of things. We can give advice directly to the citizens as they come in, and this is Phyllis giving advice about the tick and telling a concerned mother who probably got the tick one of the kids might have gotten bitten, about the ticks and Lyme disease. And that's some of our material that we use to send the ticks to the ag station. Our ticks are identified. We do most of the identification of the ticks right there, so people know that they're dealing with a deer tick or whatever. And then we'll send it off, the tick, live or dead, to the ag station for testing. And to date, since 1989, we have sent about 670 ticks to the station. And this year we've sent 200, so 220. So that you can see the interest in Stanford is picked up in terms of the tick collection.
If you get a tick and I bring it to the doctor, can you tell me what state it's in a disease of another animal? That's what.
Most of the doctors can't do that, so they send it to us.
But you couldn't tell if it was an infected tick, you could just tell whether it eaten or not.
Right. When we send it off, we get it tested, we tell if the tick is infected or not. We send.
Anyone can do that? Could he do that?
No, he couldn't do that, no.
He could diagnose, but could he send it off?
Yes, he could. He could, but what usually happens is because our relationship with the ag station, they go through the health department, so they're encouraged.
We have a nationwide tick ID and culturing. We funded John Anderson to do exactly what you want done, so that anybody in the United States or Canada can send a tick to John, care of the LBF Tick Project, and he has money to do this, not much, but he's got some, and he will identify it to the stage it is. If it's alive, he can look at it under the microscope and see if it's infected. If it's dead, he'll do PCR on it, which you do on dead ticks. So we can identify it. All you have to do is make sure that they send it care of the LBF Tick Project.
LBF what?
Tick Project.
What's the address?
123 Huntington Street, New Haven, Connecticut. I don't know the zip. It might be in.
You got it, Phyllis?
Tax-
Wait a minute.
yeah.
06504.
06504.
And we have a canister there. If you want to send a tick right now, we can just
How much is
send
that?
How much is it?
Yeah.
Free.
Three?
Yeah, but if you want to donate, keep it going, you're welcome to donate to us, but he can't accept any money there.
What kind of capacity you have?
Capacity, he'll do it till he drops. I mean, this is a board member who does this for us for free, and we fund him to buy the reagents to do it. So it's something he does. It's in New
You can
Haven.
get hundreds of requests just from Suffolk County alone. Do you have the manpower to handle it?
You would be able to handle it.
How do you send a ticket?
I think that.
He gets 700 ticks at a shot from
Yeah.
Diane Kingery up in British Columbia. I mean, it's-
But I think if he's going to do, if they send dead ticks and things, maybe I can do
I
it.
know, he's had some problems.
Okay, well, I think the way that's been handled in Stanford, and I think this is kind of, if you're doing this in your communities, what I would recommend is that you have a point person to do that. And I'll tell you why. Either an agency, like your health department, or if you had a hospital, or if there was a doc, or if there was a group that set itself up in any kind of way they wanted to deal with it. Because basically, if you start, first of all, he could, like you said, he could get overwhelmed with the ticks that's coming in, because they're going to be every tick in the world coming in there, not only deer ticks, but other ticks as well. The other part is that the important part about this program for us has been our ability to collect local information, epidemiologic information, coming through us. So we're able to, not only when we send the ticks out, we're able to keep the information and pull information together so we can do collective information.
I promise from here, I'll keep I'll collect your
No.
Some of the guys' names.
What, you can do that. I'm not talking, okay, you personally, I'm going to push on in my lecture here, okay, because it's too much. You personally can do that, but for those of you who are interested, who are interested in doing so, if you're associated with
I work the health
an organization,
I understand how
then,
you do it.
then,
Post office box, it's waste time, it takes an extra day to go on.
Okay.
Post office box 1106.
But the reason that it's important for, and I think if it's the health department, I think that's terrific. Because what happens is that you're able to collect information. When people bring the ticks in, or ticks are sent through the departments, what we do.
We have no way of finding out if they're infected.
Right. What we do is that we find out the tick's infected, but we also get other data from the citizen as well. And if we could set this up.
Can I just make a comment about the,
Also, virtually none of them come in the community. That's why out of the grass, there's grass and equipment to set them up in the proper environment so they stay alive during transport, because otherwise they never make it. They would never, it wouldn't be a part, a lot of times their container would be broken.
in respect to this testing by John, he has limited capabilities. I understand the system he's dealing with and the reagents and testing that's required. This is more geared toward individuals, the testing, and in respect to like the county health department submitting hundreds of samples. First of all, I think there'd be little information gleaned from Suffolk because, I mean, virtually the ticks are infected throughout the county. We're not gaining any advancing information. From individuals, that would be fine because that doesn't overload the system. But to send, hundreds of ticks, I know how your offices, we get, I went in just to pick up my mail the other day, get to the field, and I had to look at 8 ticks by 8:30. And these are things people show up the door with. And we don't do the testing any longer ourselves. So, I mean, you can probably work out a deal with some lab. I know the county and the CDC grant proposed to do this. But I personally think that we'd have little information to glean in Suffolk as to what John's really looking for. The new...
Suffolk is mostly going to be infected.
Yeah.
What John's set up to do is handle ticks that are sent in from individuals that are put into pill containers with a couple of blades of grass and screwed with overnight mail. A lot of times it'll come either from the patient directly, from the doctor, from the owner of the pet, or from the veterinarian. We pick up for the local schools by us, so every day we do a pickup from the schools and the ticks that they have, and then they're sent overnight mail to John. They arrive in good condition, and he does those almost right away. So if it's the health department looking to have everybody done, you may wind up making some sort of boondoggle for us, but you need to talk to John. Our system is set up for individuals, and you as an individual could send in yours, but I'm not
But I
sure.
also think there's a problem with that as well, because as our experience has been that everybody says, yeah, it sounds great, you're ready to run off with your ticks. We get everything from roaches, people bring roaches in, people bring non-animal little spots that they want tested. And unless you have some kind of way of screening those down, it becomes a big burden on the lab.
We haven't had.
And so we've
got, the selection itself is something that knows the tick's going to follow. So the selection, at least for this tick so far, has already occurred. But we used to get ticks in our office all the time with pieces of skin, ointments, and scabs, and whatnot. And we wound up being able to filter that down to ticks over to John. It's the same kind of process, but ours is more individually geared. It's funneled to John, the big project, which is funny. There's a special internal thing, same person basically, but our Bible state.
Yeah. Could we get going? Because we're kind of running. Okay, flip it on. Hello. Okay. This is some of the information that we've been able to get. When the public does come in for the ticks, basically we've been able to enter. We tell our local people about our program through the media and letters to the school, healthcare providers. We tell the physicians that they can get the ticks over to us, and we ask the people to answer a questionnaire when they submit the ticks. We also do counseling at that time, and we give information on Lyme disease. So that's why when you say, well, I'm going to look at my tick and go, I wouldn't advise, I think you're really, unless it's a good opportunity to give people information when they're coming in, they're concerned about a tick or about what they think is a tick. So it's been a very useful educational tool there. Also, when we glean data, our local data about about the ticks, and I'll give you some information about some of the things that we've been able to gather. For example, this is our cycle of tick bites, just based on the ticks as they come in, and based on the various stages. Early information, which confirms with in other places where most of the people have gotten bitten, has been pretty much outdoors at the home. Some have been away from home, and a few have been the neighbors, but most of the tick bites are around the house. This gives you some preliminary information on the age and sex of when people have gotten bitten. And Phyllis and I were going over today about this stage here, where boys seem to be less identified than girls earlier on, and the same with this in this group. So we're able to take a look at that and sort of find out why. Our question is, why is this happening? And we can make all kinds of conjectures, and we'll be looking into that. Males here start to peak up more out. You suspect more outdoors and the like, but also comparable with females. Now we don't know if the female increase in tick bites are related more towards females being more concerned about getting bitten by ticks, so thus would come more likely to come in and bring their ticks in to be identified. Many of these, even the males identified here, it's usually a female who brings the tick in for identification. So it's not necessarily a male brings the tick in, but they. Another area that we found was interesting was where the bites occurred. If the bites occurred, here you can see where the bites occurred. Usually you hear most of the time the bites, look for the bites on the legs and that sort. Well, everywhere there, and for the sake of, so it's an area where you can gather some information and you can give this to the public as well as to your professional peers. There we do the identification. We identify the stages of the tick right there in the laboratory. One other aspect that you should never forget is, if you're doing community education, is involve your local elected officials. Involve them. We have our mayor giving out proclamations for Lyme Month, the Lyme Disease Month, and involving the elected officials is a very important aspect of getting things accomplished and recognition. It also gives you an opportunity to get resources that you wouldn't otherwise get. Like I said, we don't have any identified resources. We didn't get a grant from anybody. We haven't gotten any special city appropriation for this. This has been mostly all through redeployment of our existing staff and using resources that are out there. There's also, we work under the philosophy of see one, do one, and teach one. Once you find that you're involved with some of this, and you do it, and pretty soon people are coming to you for consultation. Other departments, we are also consultants to other departments that come and ask us on how to deal with situations. Even state agencies have asked, our state agency has asked us how we deal with certain situations. We communicate with the doctors, the nurses, and that community. We have newsletter. We have a letter that goes directly to all local physicians about Lyme disease. We not only encourage them to report, which is an uphill battle, but we also inform them about conferences, newer findings in Lyme disease, and considerations. And it's been very helpful in keeping the physicians and the hospitals up to date. One of the things which is a plus for just a local health department at the end of the day is that we're able to participate in engaging research, which, now, as a health department, we don't get paid to do research, and in fact, our interest is not in primary research. We have to deal with whatever we got, we have to deal with it. And we're not that persnickety about research. However, where research can be a public benefit or an education benefit, we participate, and where there's a public health return. Here we're doing the dragging and flagging for ticks. This is part of we're trying to retrieve ticks from the wasp release program. We released the Chalcid wasp, which parasitizes the tick. And we released the wasp last year, and now we're trying to find infected ticks, who carry the eggs of the wasp. It's an experiment that's being run out of the Connecticut Ag Extension, and we're participants. Again, it helps them it helps the Ag Station, Dr. Anderson, it helps them in terms of there's some more people out there helping with their experiment, but it also helps us in that we educate the public about ticks and Lyme disease in our area. We also, that's Phyllis, I think we got it, we nailed the tick there, yeah. And those are just collecting the tick. There, we also trap mice. We did mouse trapping and looking for the ticks in the mice in our area, and been able to gather information on the extent of infected mice in our area. So again, this was another area where we participated in publicly supported research, but also we were able to get a return from a public information point of view through our local press, and like I said, that mouse, I think that might be the Newsweek mouse. Our tenets are very simple. Generally, our tenets and our principles are, we listen to the public, and I feel that the public is ahead of public health leadership in this area. I think public health and even the healthcare community is behind the curve on this one. I think there's been a lot of, there's very few resources, less resources than should be brought into this area, and I think it's something that we need to catch up on. But we try to listen to the public. We utilize existing resources. We turn loose the committed and the competent, such as Phyllis, who's with us here. She's very aggressive in terms of getting out there. We prod the unwilling and the reluctant. There are many people that would just soon make this problem go away by ignoring it. And we take advantage of the freebies. There are many freebies out there, you just have to find them. There's a bumper sticker that kind of typifies what I think we like to do in Stanford, and it's by some environmental group. And their philosophy is you think globally and act locally, and that's the way we like to do things in Stanford. We feel we're very proud of our program, and very proud of our community and its response. And Stanford, like many communities, is sensitive to its image. And there's all kinds of things people get nervous about. Well, it will be considered a tick capital and all that. But the citizenry is appreciative of our department and is appreciative that we are involved in an area in which they have a lot of concerns about. So when you get in touch with your citizens, the person on the line there, this is when your elected officials become a little bit soft. You got to go right directly to the people. Where you can talk directly to the people and listen to their concerns, and they find out that you're involved and interested in their areas. You don't get this backlash of being stigmatized, so stigmatizing a community. You'll find the community is responsive and very positive. That's it for my lecture. If I have open for any questions, if you have any. Thank you.
video man ready. Okay, well, like I said yesterday, I've known the last speaker in this session intimately for some 40-odd years, and all I can say is a pretty nice guy. So with that introduction, I'll get down to talking about some of the veterinary aspects of Lyme. It's somewhat disappointing to see the crowd dwindle by the end of the day at a meeting like this. Not so much that I'm talking to an intimate crowd, but the fact that people seem to want the medical information and split. What they're not realizing is that the dog is going to answer a lot of questions that were posed this morning to the physicians, whereas we can't answer them directly from the humans in respect to use of an animal model for patterning this disease. Well, as I would like to indicate, we can go on the next slide, Ed. Veterinary Lyme disease is an increasing problem. It is naturally manifest as disease in dogs, horses, and cattle at this point. And as I said, it will lead into some answers for human disease. The first clinically described case was a Doberman Pinscher from Long Island. And it's what we will call from now on the index case in the dog. It was reported in 1984, and if I have the next, the dog presented with an acute onset of pain and stiffness in all its limbs. The pain was migratory and intermittent in the carpal joints. It was febrile and would not eat. All blood parameters were normal, as were x-rays or radiographs. We were successfully isolated Borrelia burgdorferi from the blood on the first two sampling dates. And this was around Memorial Day and the first week in June. The antibody levels were high with IgG and remained consistently high, and it was persistent. The ANA, or autoimmune antibodies, were negative, as was rheumatoid factor. And we detected no cross-reaction to the leptospires that I mentioned previously. And the rapid response antibiotics gave us the indication that this was a first true case. This is the, am I advancing this or are you? Is it? Oh, I thought I hit something. This is the spirochete isolated from the blood of that dog. You can see the typical morphology, and we, by use of monoclonal antibodies, proved it was the organism following culture. Now, the key clinical markers, next, that we used were obvious lameness and high fever. And unfortunately, we've been stuck with these clinical markers since our description of the first case. Now, in Connecticut, they saw two categories of clinical presentation. The first of these being acute onset of fever, about 103 to 105, which is high. Lethargy, anorexia and depression, and generalized pain in the joints. And the second category was intermittent single joint lameness, most commonly in the carpal area, the elbow or the hock. And this was accompanied by soft tissue swelling in the joint, but no bony lesions. This paralleled pretty much our clinical description, and lameness in this case might be migratory, and the accompanying fever was generally of low grade. Next. Now, taking the fact that our clinical marker was lameness, we retrospectively took data from several studies that were called seropositive asymptomatic or non-lame dogs. It was becoming apparent that there were a large number of animals that had inapparent infection or subclinical infection. And based on the lameness, were considered asymptomatic totally. I think now we're more appropriate in saying these are actually inapparent or subclinical infections. The dogs in Wisconsin, in the survey of 380 dogs that came into the University of Wisconsin from random source vendors, of those 53% were seropositive, but not lame. And of these, 8 dogs had spirochetes circulating in their blood at the time of sampling. In a study we did in New Jersey to determine the value of the canines as sentinel animals for tracking this disease and for predicting risk of spread of human disease and spread of ticks, Out of 423 dogs we sampled, essentially in the freehold area, 34% were seropositive. Now, of these, we monitored 10 other dogs over a period of time from this study, and 7 of these, or 70%, developed lameness. So it appeared that the lameness was a late development in a seropositive dog. So we have an indication here that seropositivity in an asymptomatic animal or non-lame animal may be a predictor of forthcoming disease. Now, we also demonstrated that we could use the dog as a serosurvey tool for determining risk. This has been applied in New York State, well, had been applied in New York State. We're monitoring dogs up the Hudson and west of the Hudson and tracking Lyme disease. We were getting very good results on the advance of the disease and ticks. It seemed that the dogs would become seropositive in areas, and we go in the next year, find ticks, and then human cases would follow about a year later. So we had a good tool for predicting risk and monitoring this disease until the dog vaccine became available. And within the last year, that has essentially put this serosurvey to its knees, because the dog vaccine is being administered in areas where we not necessarily have disease, but we're now picking up positive antibodies and don't know whether that's related to the vaccine or whether it's natural exposure in the area. So, continuing in New York, on Long Island here, we did a survey on the East End using heartworm bloods that were screened for heartworm. And we found that we had a range of 35 to about 80% or 78% that were seropositive, but here again, non-lame dogs. In a more complete study, or a more refined study, we looked at the canine corps of the Suffolk County Police Force. They have 21, or now 22 dogs, a mixture of retrievers and shepherds, essentially. And these dogs are worth about $20,000 apiece. So about every 4 months, they get very extensive, complete physicals. Part of this is my Lyme disease testing for them. The first year of testing, on the initial sample, we had 66% of the total force that was seropositive, but quite obviously non-lame. 3 of those dogs that were seronegative on first sampling became seropositive by the spring. So quite obviously they had some type of exposure from the fall, which was October, through the spring, which sampling was in March. These dogs are very important dogs because, as I will explain later, we're seeing that lameness is not the marker we should be necessarily using for Lyme disease in dogs. There are many more subtle effects and probably earlier effects than lameness. But when the dog is presenting to the client and to the veterinarian, lameness is still the most frequently reported symptom. It's what everybody notices, and the vet doesn't see what happens at home. He only sees a lameness when you bring him in. But we are finding now that there's a great deal of parallel between the dog disease, the naturally infected dogs, and human illness. And that will lead us to the development of an animal model. The canine corps is of particular importance because we are now getting reports from some of these animals, the handlers of these animals, and these animals live with their handler 24 hours a day, that they're losing cognitive responses. They're not responding to hand signals like they used to. Their sense of smell is disappearing. And if you have a dog that its mission is to go after bombs, you certainly want the sense of smell to be operable. And this may be a result from Lyme disease. After treatment, these dogs regain these senses. So it's not a definite cause and effect because we don't have the samples we need to evaluate, but certainly the footprints in the sand have to lead somewhere. And we're believing that this is probably part of the Lyme disease scenario. In North Carolina, where they don't really have a lot of Lyme disease, the number of seropositive dogs was much lower, but essentially was increased as you approach the coast. In Northern California, the same type of similar coastal phenomenon, and here again, lower than we have in the Northeast. About 24% were seropositive, and here again, non-lame animals. The point I'm trying to drive home here is that we can't use lameness as a dog being a non-Lyme dog. And the next one, Ed. Now, Ed Schneider took a look back on seropositive dogs that were submitted, or that he tested, that submitted to his laboratory. And retrospectively went back and asked the attending veterinarians what symptomology these animals had at the time of sampling. And here again, there's 1,500 dogs in this study, and the symptomology is listing from the most frequent to the least frequent at the bottom. So here again, you can see that lameness or arthralgias were the most common, followed by lethargy and inappetence, generalized pain, renal disease, fear of unknown origin, neurological disease, including central nervous system involvement, lymphadenopathy, facial palsies, upper respiratory infections, gastrointestinal upsets, and uveitis. Now, as you can see, these symptoms parallel human disease, not necessarily in frequency of decreasing order, but in association with a seropositive animal. And in retrospective analyses, 3 areas became very important: the category of renal disease, the facial palsy, and neurological disease. Now, a retrospective analysis, again, of the renal disease revealed that 30% of the dogs that had renal disease, were seropositive, had renal disease either 4 months before, after, or concurrently with any lameness was present. The renal disease in this case was broadly classified as anything from urinary incontinence to glomerulonephritis to complete renal failure. Now, after the study, the veterinarians called in an additional 3% developed some aspect of this broadly classified renal disease 1 month after the final survey. And the attending vets in most cases indicated that the numbers were totally disproportionate to the normal numbers for kidney disease normally found in their areas. Now, we look at the neurological disease indication. It can be anything as unremarkable as a facial twitch. It can have a behavioral change, such as aggression toward companion animals or the master, lethargy, and as dramatic as seizures were the most commonly reported neurological disease from this survey. Now, facial palsies, which could probably be akin to the Bell's palsy in human disease, were supported subsequently by a finding in Massachusetts where a dog presented with a unilateral facial palsy, and Lyme disease was the suspected cause in that case. Now, the next one, Ed. These are what is in the literature now, the clinical associations. The fever, malaise, and inappetence, are joint involvement, the inflammatory arthritis, renal disease has been reported, glomerulonephritis, complete heart block has been reported, and some neurological disease was suspect by Dr. Schneider in 1988, and I will go through that one in a moment. The next one, Ed. So this is the way we look at canine Lyme disease at this point. And if you just think back and remember what human disease does, you have early infection where you have the EM or the former ECM, the erythema migrans lesion. Now in dogs it's not very evident, if it's evident at all. We're not sure. You have fever and lethargy. Then as the disease becomes disseminated, as Dr. Birascano pointed out today, it's probably in relatively short order. You have arthralgias, arthritis, generalized pain, nervous disorders, uveitis, cardiac involvement, hepatic involvement, and renal involvement in dogs. And in late infection, by late infection I mean infection that is persistent for 6 months or more, you can have chronic lameness, renal disease that's chronic, potentially leading toward death due to renal failure, and cardiomyopathies and chronic neurological disorders, which can end up in seizures. So this is the way we look at Lyme disease in the canine now, as non-staged but early and late infection with a non-disseminated and disseminated phase. This is a putative EM lesion from a dog in the Stony Brook area. You can draw your own conclusions on this one. Based on the relative size of the thumbnail and the EM lesion, and without histological backup, nor punch biopsy culturing available to us, I would have my doubts that this is a true EM lesion. We do not have a follow-up on this dog as to whether the lesion expanded or not. That would be one of the definitive distinguishing indicators for EM, but the ultimate goal would be to get a punch biopsy and culture the organism from this lesion. This looks more like a tick bite reaction, hypersensitivity reaction in my estimation, but it could truly be an EM. We need the organism from the biopsy material. Next. Here you have swollen joints, and on radiograph, the next one, you can see the swelling and perhaps a tad of soft tissue swelling as well. Next. This is an example of the behavioral change, more than likely related to Lyme disease, in a dog that was very happy-go-lucky and mellow shortly before he became seropositive and diagnosed as having Lyme disease. Unfortunately, the owners elected to euthanize that animal. We do serologies in dogs just as they're done in humans. We can use an indirect immunofluorescent test, or we can use the ELISA. Now, you have to interpret a serology with a bit of caution. We have these seropositive asymptomatic animals. Now, initially that would indicate exposure, minimally, that would mean exposure to the organism. But we also feel that is a predictor of forthcoming disease. And some vets are treating all seropositive animals, at least for a one treatment regimen. Now, persistence of antibody has also been noted in dogs. And does this mean persistent infection? Well, that's a very high probability as well. We do think the organism is persistent in dogs as it is in humans, in the tissues, deep in the tissues. Or in an endemic area, does it mean reinfection? Well, my way of thinking is probably both. I mean, I find it hard to believe on the east end of Long Island that dogs that are constantly encountering ticks are not being reinfected, even though they may have an infection that's persistent already. So I think it's a combination of both. Next. Now, as I said before, we use the serology as a tool for predicting disease, the serosurvey. The next one. And this is how Lyme disease looked in 1986 in New York. And you could find 90% of all the seropositive dogs within these areas. So you can see Shelter Island had the highest incidence. This is human disease at this point. But the dog disease parallels the human, so that the incidence of dog disease was probably 10 times the human in these areas, but it paralleled it almost identically. Shelter Island had the highest incidence, followed by the East End, South Shore, and then areas in Westchester County. The next one. In 1987, this is what the disease looked like. It was progressing northward and westward in the Hudson Valley and moving westward on the South Shore. Shelter Island was not the red it was the year before. It had lost. The reason being, I believe that this is when the samples were sent. Originally they were sent only to Eastern Long Island Hospital, and now they were split between Southampton and Eastern Long Island. And those two hospitals being on opposite forks of the island, they're reported as different areas. So Shelter Island was diluting the caseload to two different areas. And this is what the picture looked like in 1988. You can see we're still a continued expansion of this disease at a rapid rate, almost up to Saratoga County. What we'd like to see is the area around Albany become bright red, and then we will probably get funded to do some decent work. But I mean, here we sit down here in the southeastern portion of New York with the highest levels of Lyme disease, the highest levels of seropositive dogs. The seropositive dogs marched right up the Hudson Valley just like the human disease, but prior to the human disease. We were able to pick up dogs that were seropositive before human disease was being reported. And they said now that survey tool has been completely removed from our arsenal of weapons we can use to monitor this disease due to the current vaccination procedures and vaccinating in areas where we don't know they have disease or not. So it makes it very confusing. So we essentially disband that method of monitoring disease spread. Next one. Okay, another thing that you can do with and I'm surprised we didn't see a lot of Western blots today, but you can take the blood of a dog, the serum of a dog, and if it's reactive to in an ELISA or an indirect immunofluorescent test, you can determine exactly what proteins of the organism it's reactive to. And that's as much as I want to get detail on this. If you have any questions, I'll be happy to address them. But the proteins are broken up and separated and pulled down they're on this paper. So that each protein has a different band. And the numbers on the left are how much their molecular weight is. So they're all separated out. And then you react the serum to this and you find out exactly what protein stimulated the antibody response, or the antibody was made against that certain protein. Now in early human disease, you can see right before the number 40, or below the number 43, there is a band. That's a reactive band. And in early human disease, this is what occurs. You get your first immune response to this band. As disease progresses, next one, and you have true chronic disease of 3 years, you still see below the 43, you have that strong, intense band. And that's the 41 weight molecular protein, or molecular weight protein. That is the flagellum of the organism. We know what that protein is. We know its function. We don't know what epitope or whatever it's reacting to, but we know what that protein is. That's a genus-specific protein that allows you to classify this reaction to the genus Borrelia at this time. If you have the two bands above the 25.7, one of those is a 31 kilodalton protein, the other is a 34 kilodalton protein. These are outer surface proteins of Borrelia burgdorferi. They are species-specific. We can say that we can say this is not syphilis, it is not relapsing fever, but this is Lyme disease reactivity, if those two bands react. Now, the number of bands in humans of chronic disease, these are patients with at least arthritis of 3 years duration. You see, you have maybe a maximum of 15 intense bands. Now, on the next slide, this is the dog that we first isolated the spirochetes from, had Lyme disease. And you can see on the first day, it had strong reactivity to essentially as many proteins as the human disease, but many more in the second sampling, which to me means this disease is persistent because the antibody is being made to many more small proteins that humans don't recognize, which means the organism has been around a lot more in the body, and while it's being broken down, the immune system is finding these smaller proteins and making antibodies against them. That is why we feel this is persistent in dog. The next one. These are dogs that have had a variety of symptoms. The first one in lanes 1, 2, 3, 4 merely presented with an ear infection the first day, then came in for behavioral changes, then had lameness, and then renal failure. So this is a dog that ran a gamut of several symptomologies and finally died from this disease. The other ones represent lame dogs. But here again, you can see you have those two intense bands above the 25, which are the outer surface proteins, indicating it was Lyme disease. So next one. Now, the first indication we had neurological involvement in the dog was Dr. Schneider had a case. It was a 12-year-old German shepherd, presented with a fever of unknown origin, had cells in the cerebrospinal fluid, had seizures in the hospital. A spirochete was seen from blood smear, and it appeared to be Borrelia burgdorferi, but we did not have the immunological probes available at his lab at that point in time. And the dog also had high levels of antibody to Borrelia burgdorferi in both the blood and the cerebrospinal fluid. Next one. Now, go to the next one. That initiated a study that was funded by a grant through the foundation that our lab did with the Animal Medical Center, in conjunction with the Animal Medical Center in Manhattan. Now, our mission here was, can we detect antibodies to Borrelia burgdorferi in the cerebrospinal fluid of dogs? And if so, how does that compare to serum antibody levels? And if intrathecal production, which is production of antibody in the central nervous system, if we can demonstrate that, is this going on in dogs? And can we confirm this with a Western blot that it's actually to what the organism we're looking for? And we're trying to determine if there's any clinical correlation between the antibody level and neurological symptoms in dogs. And to make a long story short, what we came up with was we had 6 dogs out of 50 that demonstrated intrathecal production, which would be the yellow bars of antibody, which is antibody produced in the cerebrospinal fluid. 4 of these dogs had also serum antibody levels, but the antibody levels in the cerebrospinal fluid were higher than the serum levels. And 2 of these dogs actually had no serum antibody, which means the antibody was produced in the central nervous system. And the only way that I'm aware of that antibody is produced in the central nervous system is if the organism is present in the central nervous system. So we had fairly direct evidence, or indirect evidence at that point in time, that the Borrelia was getting in the central nervous system of dogs. And we were probably getting neurological disease based on this. Next one. So we took it a step further after we demonstrated intrathecal antibody production because we had specific antibody in the cerebrospinal fluid regardless of what was found in the serum. Then we looked to see if we could prove that the organism had invaded the central nervous system. So we looked for the specific proteins that I mentioned on the Western blots a moment ago, the 2 species-specific 31 and 34 KD proteins and the genus-specific. And through the use of a bank of our monoclonal antibodies, we could pick out those proteins in the cerebrospinal fluid of these dogs, which would mean the presence of the organism. We took that even a step further with the polymerase chain reaction using 3 primer sets, which will pick up pieces or areas of DNA from the organism. One of these was directed toward the outer surface protein A, the other toward the flagellin protein, and one toward another outer coat protein called the 12KD. We're not sure exactly if this is an outer coat, but we're assuming it is. So we did have direct evidence at that point that the organism was in the central nervous system of dogs. Now here is the natural infection, the clinical involvement that we know of at this point in the dog. And I must say it's not complete, because what we're trying to do now is develop a dog-animal model, because the dog parallels human disease and can be used for vaccine trials at that point and for studying the pathogenicity or pathogenesis of the disease in humans. What we have right now is a clinical definition of natural infection in dogs, which is incomplete. We have not proven beyond a shadow of a doubt that erythema migrans does exist in dogs, although we would highly suspect it. We do have limb and joint involvement, and still the most frequently reported symptomology, and less frequently have the kidney disorders, cardiac abnormalities, which would be infections and arrhythmias. We do have now CNS symptoms, behavior changes, and seizures, which we have fairly well documented are caused by this organism. So in the next slide, this is the state-of-the-art of the canine animal model at this point in time. It's all been experimental infection using either tick, stomach contents, or primary cultured spirochetes, which are still virulent. The best that people have been able to do at this point in time is reproduce spirochetemia, get antibody production, produce some lameness in not very many animals, and have been able to demonstrate horizontal transmission. Well, actually, this has only been demonstrated by the manufacturers of the vaccine, who in the first trials demonstrated that 100% of the dogs could pass the spirochete without a tick vector. In the second go-around, it was 0%. So I think we better give them best 2 out of 3, have them do it again so we can get a definitive answer on this. But nonetheless, that's the state of the art. But we are planning now to expose dogs to natural infection and follow them for quite a while. This is partially supported by the grant through the foundation, and the gratuity, the graciousness of another installation is providing us with a place to do this. I'm often asked, what are the public health implications of dogs? And here again, we're not really sure. We could use, or we used to be able to use them as a predictor of human disease risk in new areas, new geographical areas in New York. I was asked this morning about the reservoir capabilities when passing the infection to ticks. We're not sure on that. It probably does occur. We don't know the frequency. Can the ticks maintain their populations by feeding on dogs, as they would on raccoons or deer? We can recover many ticks from dogs. We do not know whether they mount an immune response to the tick bite and whether the tick will die after feeding or whatever. This has to be looked into. Dogs, in my estimation, are a major vehicle for the spread of ticks throughout the state. And you consider that the disease has marched up to Albany in a matter of 3 or 4 years. Ticks don't move that fast. And dogs carrying 100 or so ticks from Long Island back to a home site in Albany County could feasibly move that fast. Birds have been implicated in the spread of disease. I think it's very important, but again, they don't seem to harbor the number of ticks that dogs could actually carry in. So dogs may be very important in spreading this tick around. We don't know about the contact transmission between dogs and dogs or between dogs and their owners. If it does occur, in my estimation, it would be very, very minimal, very, very low frequency. We do know that the dogs do bring ticks into houses, and if they are attached, they pose no problem. They will not leave the dog to feed on you. The problem arises in the fact that those ticks that are still roaming through the hair, and the kids lay on the dog, and this tick decides, well, I'll just walk onto the human and eat there. But generally, they don't pose a problem unless the ticks are ranging through the fur. These ticks will not live indoors either. They will dry out and die. So with that, I will stop talking about the veterinary aspects, but I just think it's a way that we are going to determine, since it is such an intense disease in the canine population, it is going to provide us with the animal that we can naturally infect, and it demonstrates all the natural symptomologies of Lyme disease that we see in humans, that we will have an animal model from which we can work backwards. We're in an ironic situation. We're using a human animal to pattern a veterinary disease, when usually it's the opposite around. We use a lab animal to pattern human disease. So we thank the humans for helping us in this cause. But if there are any questions on this, I'll be happy to answer it. Yeah, yeah, dog to dog or dog to human. It's been suggested in Wisconsin by indirect evidence. And
Isn't it mostly eating urine, though?
eating what?
Aren't they talking about a behavior humans don't have? Close contact and eating urine and...
No, I mean, you consider a pet groomer, a veterinarian. And I used to raise puppies. I used to pee on papers, and I'd pick it up and take it out. So, I mean, it may be an occupational hazard, you know, if you're in the pet handling industry. Pardon me?
How would the transmission work?
More than likely it would be urine transmission.
Spirochetes going from throat to skin.
Or mucous membranes. Theoretically, with the mouse model, the female mouse has viable spirochetes in the urine, and the neonatal mice are attached to her. And she has to urinate sometime during the day. These little guys are hairless and exposed mucous membranes. And it's very possible that the mother mouse could infect the mice attached without a tick vector in the wild. This may be ongoing. We're not sure. But if it is, I think it's only in our area, since we're the only ones who can seem to be able to find this phenomenon. But well, you'd have mucous membranes, same like lips, eyes, that type of thing. They groom one another, and the female, quite often, this is the very indirect evidence at this point, but it certainly could occur. And the female, the dog will clean the pups or actually stimulate them to urinate.
What has to be corrected?
A seroconversion from putting an infected animal in with a clean animal, and the clean animal seroconverts. Well, this has been done in a laboratory facility.
Yeah, we're trying to inoculate, uninfected animals.
Biggest problem, nobody had access to the data.
It's not our data. This is, it's been published.
Isn't the dog's nose mucous membrane?
Pardon?
The dog's nose,
Oh, that's a mucous membrane, yeah.
like everything.
That's for sure. That's for sure, right?
I don't think he's implying.
I'm not implying, these are questions. We don't know the public health implications of these factors right here. It's something that,
Some of the answers are there. It seemed like simple inoculation procedures to use the membrane, approve or disapprove.
well, I mean, it is a relatively simple thing to do, but it's a lot more difficult than it sounds. If you're working with animals, as Dr. McLean pointed out, he has trouble even touching an animal in Colorado. You have to go through a lot of committees in order to get the animals. You have to have approvals from an internal committee, not only your department, but the facility you're working at. And this involves public members. It's not only scientists in there. Then funding becomes an issue because you have to house these animals in certified installations, which are NIH inspected, so they're not like you take it to a local kennel and throw it in there. These have to have positive ventilation systems that you can switch to negative ventilation systems. They must have surgery suites and all this type of thing. So in order to keep a dog for a day at the university, it's $28 a day to keep a dog. And if you're talking about Lyme disease, it could take you 6 to 8 months to establish that you have an active infection in that dog. And I mean, the funding's not there to do it. That's part of the reason we're finally getting around to doing this modeling because of the grant through the foundation. It has given us the opportunity and the donation of the facility by a major company that has the dogs already.
There's a lot of research on Lyme disease. I mean, you're asking what common sense questions. And there's a lot of research on Lyme disease that should, in an organized world without other motives to doing research, an organized way, if everybody got along and did all the research at the same time, you would think that would be done, as well as a lot of other research. What happens? That's what we've been trying to do is plug up holes in things that we thought should have been done, like the Lone Star tick, transmission, other kinds of ticks. Sorry, testing, nobody else is having a direct protection test. There's a lot of things that should have.
Ed, there's a couple more slides on that, the end of that someone was saying.
You talking about the transfer of ticks from animals to humans in the household, but need we be concerned with different ticks if the human disease comes from a particular tick that doesn't infect or a host? I'm talking about different ticks. The one the dog brings in and the one that will...
No. The dog actually harbors a variety of ticks. The Dermacentor variabilis tick that Terry had a picture of this morning, is the mahogany-colored tick with striations on it. That is called the American dog tick. The Ixodes dami, the deer tick, very commonly feed on dogs. That's how they get Lyme disease. The American dog tick in this area brings you Rocky Mountain spotted fever, which is a much more serious disease than Lyme disease if you don't catch it, because you're dead. I mean, it's a quick kill. But, so you have 2 tick species feeding on the dogs, so you have to be concerned about all of them. But the point I was trying to get at is the ticks that are attached to the dog, unlike flies and mosquitoes, are not going to back out that dog and say, the humans taste you, I'm going to leave this feeding spot and go bite that lady. If they're not attached and they're just roaming through the fur, haven't attached yet, that's when the danger arises. You start petting the dog, or the kids lay on it, or it jumps on the sofa, that type of thing. That's when you have to start worrying. But the risk here, even then, is minimal. What? One spirochete that causes Lyme disease, yeah. I mean, there are other spirochetes also, but we don't have them in this area. Yeah.
The dogs and all horses have false negatives, results as humans do. And do they have prolonged treatment with IVs in less years, and do they get hurt from it?
No, yes. They do get Herxheimer's reactions. We've seen this in several animals.
I had a big argument with that at a horse show. We had a horse out there with Lyme disease who was retreated, was obviously not performing up to its level, and I went up to that and I said, "Of course, you're having a Herxheimer reaction. What is that?" Laughed at me, said, "Human ailments have nothing to do with animals. Immune systems are completely different. You can't expect." It was a big, lengthy argument, and I thought it was. So where can I find this in writing?
Oh, it's not in writing, but what I would suggest you do is give either the vet's name to Karen or tell the vet to call Karen in the next conference to come. Because then you'll have a chance to talk to people that know what they're talking about. It takes about a year and a half to get something in the veterinary literature. So if we want to publish something today, it will be at least a year and a half from now, you'll see it. That's why sometimes discourse at meetings is a much faster mechanism of getting across. And that's the whole purpose of this meeting, the education factor. So you don't have to wait for the stuff that's coming down the pike. And wait a minute, I got to answer two more parts of that question. Where were they? I forgot. That's more than likely what happens. You're talking about IV therapy, that's in-hospital treatment. And the drugs, as we heard, are not inexpensive. There have been some attempts by certain individuals who are breeders to maybe put their dogs on some of the high-cost drugs because they're valuable dogs. But there's really not a lot of success. We don't have a lot of good data points with that because it's they seem to respond within 48 hours. If I've seen dogs that are down, can't even get up, give them antibiotics for you. See, we don't know. We don't know. That's why when you're dealing with the vets, it's much like dealing with physicians. You get a piece of information. And, I mean, that's why dealing with physicians is a lot easier because they have to fill out forms. The vets will send you a sample, and then we'll ask them, can we have a punch biopsy of that EM you're talking about? No. So we have bits and pieces. Now if we develop this naturally infected model, we will be able to address those questions. So if we can make the dog sick and go through the same symptomology as humans and recover the organisms from the same systems, we can also treat and see if we're effectively getting rid of that organism. Because our sampling technologies are going to be way advanced for this modeling study. I think you should make veterinarians more aware of it, but I mean in our area, the Long Island Veterinary Medical Association meets every month on the third Thursday. And Dr. Schneider and myself have spoken there, 3 times in the last year?
Where do they meet?
SUNY Farmingdale, right? It's closed for the summer. Yeah, the school's closed, so that's why. And what was the other, the seronegative or false negative? According to what we saw originally, no. But now we're seeing that we have cerebrospinal fluid production of antibody and none in the serum. So that opens a whole new ballgame. You know, something as simple as a behavioral change may be CSF positive, serum negative, and you still got an active infection of Lyme disease. So we'll have to reevaluate that. But more than likely, when we do a serology and confirm it with Western blot, we do have a true negative or a true positive. I do it myself. Oh, I have no idea on that. No, there's veterinary labs set up, veterinary clinic. What, to the labs? No, I mean the labs are fine. I'm just saying that every time we've done these tests, we see a good correlation between positive and illness and negative and no illness. But right now, with a negative serum antibody and a positive cerebrospinal fluid antibody, that would have been reported back as a seronegative because not every vet's going to take a spinal tap. And it's not an easy proposition on a dog. So we have to reevaluate that, but I'm saying there was great correlation between our test and illness. Our specificity and sensitivity was excellent in the test that we developed, and we use an ELISA. but it's only for research purposes. Anybody else? Okay, now, there was one, what? You wanted to see the 2-year life cycle. Do you want to stick around after everybody leaves, and I'll go through that with you? Okay. Okay.
Thank you for coming. Spread the word, and goodbye.